Hi everyone, my name is Brooke and I'm here part of the Invisi team and thank you for joining us today in watching part 2 of our Q&A video. And in part 1 we discussed a few more general bladder health questions, and in this video we'll be going through a few more specific questions that relate to certain medical needs, treatments, medications, so a few more in-depth questions that we had received. Again, we'll be taken through and guided through by the lovely Rachel, our continence nurse. So she'll be giving all of her expert advice in response to the questions that we had coming through, which is amazing. So the first question we're going to be talking through today is one that asks, I've tried seeing a pelvic physio, have used tablets by Bioglan and use Vagifem twice a week, and also limit my fluid intake. What more can I do?
Yeah, great question. So I'm assuming that you're a woman if you're using Vagifem. We're looking at estrogen products, estrogen products. Seeing the pelvic floor physio is a really great thing for anyone to do. And limiting your fluid intake. So what more can you do? I would suggest at this point that we're looking at having a good step back and an assessment of everything that's going on in your life. Let's have a look at what's contributing to your symptoms. Let's have a look at what your daily habits are like. How much are you drinking in a day? What are you drinking? What's your diet like? How's your bowel performing for you as well? Are you on any other medications? And are they maybe contributing to what's going on here? Sometimes a part of the story is somebody might be on a medication or a product that's a diuretic. And that makes you actually wee more. So that can be a part of the story as well. So what more can you do? I'd say have a conversation with a different type of therapist. So a continence nurse specialist, that's a registered nurse that specializes in incontinence. That's sort of what they do with their days, is they talk to the people about bowel and bladder, and also talk to a urogynecologist or urologist if you're a male. And they can have a look at things on a slightly different level as well. You can have a look at your anatomy. There are some medical tests that can be done, like a urodynamic study that can tell us a lot about how your bladder actually behaves, and having a good look at your pelvic floor, doing an ultrasound. If you've had any children, if you've had any natural births or cesareans, sometimes that forms a bit of the picture as well. So having a little bit more of a look, a deeper dive into what's going on, I'd probably suggest at this point.
Yeah, awesome. For our next question, it asks, how can I manage interstitial cystitis, which increases urgency and pain? I also deal with Parkinson's. I'm too slow to get to the toilet. Any tips when trying to travel?
Sure. So interstitial cystitis, what we're looking at is cysto is the bladder and itis is the inflammation that happens. You've got a cranky bladder interstitially on the inside of it. So you've got a bladder that's really sensitive and really unhappy, and it's making you feel really uncomfortable. So how can you manage that, which increases your urgency and pain? There is a medication that a urogynecologist or urologist might prescribe for you, and that's a fairly sort of benign kind of solution that can be instilled into your bladder on a semi-regular basis, and that can help to calm things down as well. We want to have a look at what's actually making your bladder feel irritated. Can we work it out? Or is it a bit idiopathic? And idiopathic means that we can't find the source or the reason for it. Doesn't mean there isn't one. It just means that we haven't been able to find it in all of the diagnostic testing that we've been doing. So you're not imagining it. It's just something we've got to work our way around slowly.
Okay.
So how can you manage that when you've got this increased urgency and pain? Just get some really good conservative habits. Take the advice you're given in terms of what's healthy for your body. So eating the right kind of foods, putting the right kind of fluids into your body, trying to keep your body calm and happy and healthy, getting yourself up and moving as much as you're able to and as much as being prescribed for you. That's really important as well. And maybe having a doctor or a pharmacist have a look at the medications you're on, see if there's any polypharmacy going on. So that's any more than 5 medications. If you've got a long list of medications that you're on, sometimes they interact in funny ways, and they can be the culprits of stuff that are going on as well.
Right.
So if you're too slow to get to the toilet, tips for traveling. Right. If you're a male, the Urodome is a very helpful thing to use if you're traveling. It's a little condom that you slip over the end of the penile head, and you can attach a drainage bag. It's a catheter urine drainage bag. You can pop that onto the end of it, and you can secure that bag to your leg and have it underneath your clothing. And if you're leaking quite a lot, it goes straight into that bag and no one even knows it's going on. That can be a really helpful thing if you have, if you're sitting in the window seat of an aeroplane, you can't get up to go to the toilet every so often. Or if you're on a long journey, that can be really helpful in containing that urine and keeping it off your skin so that you're less likely to get any dermatitis from it. So that can be a very helpful product. For women, it's about having the right kind of containment, the right product that you can rely on. So a really good quality product. Doesn't have to be the most expensive product out there, but make sure that you're getting one that makes you feel confident and secure that you've got a certain amount of time before you're going to have to change that pad again.
Yeah.
You can get booster pads. They're the little thin ones that go inside a disposable incontinence pad. These don't have any backing on them. So they're not like a menstruation pad that have got a plastic lining on the back. These ones, the fluid and the urine goes straight through to the other layer of the pad. So that can also buy you a bit more time. You can just slip that pad out and throw it in a sanitary bin, and you've got a little bit more time with the pad that you've got, or you can pop another one inside. So that can be helpful to remember as well.
Mm-hmm.
But best thing, really, talk to somebody who's had experience with this. There's a lot of Facebook forums out there where you can get some helpful, friendly tips from people that not necessarily clinicians, but they have incontinence and they travel. They might be able to give you some creative solutions for that sort of thing as well. But as first point of call is always find a specialist that understands you and your body, give you some really good sound advice.
Awesome. It's so important to get support, and off the back of that idea, we do have an Invisi support group where members can share their own experiences and thoughts in relation to bladder health and their own personal questions that they're free to ask. It's a very safe space, so it's a great one to join in. So our next question is, I have bladder leaks all night, and it has been since my osteoporosis caused fractures in my pelvic area. I had surgery, which appears to be working. The only problem is the repeated passing of urine. Have you come across this before?
Yeah, so the surgery, I'm assuming, was for the fractures in the pelvic area. There's an article that I came across a few years ago, which I thought was really interesting, and it was saying that women who have hip replacements, it's not that the hip replacement surgery actually fixes the incontinence, but anecdotally, they noticed that women who'd had their hip replacements were reporting that sometimes their urinary incontinence actually improved a little bit. That leads me to think that there's definitely a link between pelvic damage, whether it's the nerves or the muscle tissue or the ligaments, the tendons, and incontinence itself. So speaking with a pelvic floor physiotherapist is really going to understand that a whole lot more. The repeated passing of urine, I'd probably suggest at that point that you have a really good general assessment with a continence specialist, and let's work out what's really going on, because to me it sounds like there's probably a little bit more than just the pelvic surgery. Osteoporosis, so there'll be medications involved, and there might have been some events in your life like having children, those sorts of things which contribute to it as well. So that's probably what I'd suggest at this point.
So our next question is, I take 15 milligrams of Oxybutynin Prolonged Release, and my days are 100%. My nights, however, are not. Why?
Yeah, okay. So oxybutynin is a medication you can take that sort of helps your bladder to calm down. So it's not giving you that overactive feeling, that urgency that you need to go. So your days are 100%. Glad to hear that. We always want to have 100% days.
Yeah.
And so your night times are not. So I'm assuming that's saying that you've got incontinence during the nighttime. There's a couple of little things that can really make a difference with nighttime voiding versus daytime voiding in incontinence. There are people that don't have any problems during the day at all, but go to bed and they're up 15, 20 times a night. So if that's what's happening with you, I would suggest that you have a good chat with your GP and have a medical screening for a few things. Do a screening called the Tango checklist, have a Tango assessment. Let's work out what your quality of sleep is like. Let's work out if you've got any cardiovascular issues. Do you have any sleep apnea? Are you a big snorer? And maybe you have a little bit of that breathing cessation where you'll stop breathing for a second or two or longer. You might have a wife or a husband that says to you, oh, you snore like a train, but then you stop for a bit. And then all of a sudden you go, this big gulp of air, and that's just, oh, that's how they sleep. That's indicative of sleep apnea. People with sleep apnea quite often have really bad incontinence. Right. If you start wearing a machine to help you get more oxygen in your sleep, quite often you might notice an improvement in your incontinence as well. So I would say at this point, have a screen for a few things. Try and work out if you've got some lower leg edema, you've got any heart issues, you've got any sleeping issues, and let's see what's really contributing to this nocturia, this getting up to wee, or this enuresis where you're weeing in your sleep, or you're wetting the bed when you wake. Yeah.
All right, so next one is, hi, I'm looking for advice for my partner who has had MS for 40 years and is now wheelchair bound, suffering badly with incontinence. She gets up 3 to 4 times a night and wears incontinence pads and is very frustrated and gets through lots of pads, etc. Her GP said it's due to having MS and she takes lots of medication from the doctor. She is very down and is wondering if you have any people who come in with the same situation and could help to share any advice that you might think will help and support her.
Absolutely. And often these types of issues really run our life, and someone with MS has a lot going on. Yeah, it really affects a lot of different things in your life. So I think maybe sometimes this incontinence thing can be the straw that breaks the camel's back sometimes. So, first of all, surround yourself with people that hear you and understand you. And sometimes that's easier said than done. It's a matter of being in a place where you feel like you're able to actually reach out for some support, and that can be a bit tricky to do as well. So, if you can find that one first person that really understands what's going on for you, that can be really helpful. So I'd say, if you can start there, find her someone that can say, yep, I understand what's going on with you. It's not new to me, and it's not an unusual thing to hear. So let's see what we can do to problem solve. It's not uncommon to have incontinence and double incontinence, so bowel and bladder with multiple sclerosis. You can also have, you can have retention. You can have retention with overflow. You can have constipation. You can have these bowels that are very erratic. They're good one day, they're good for a few weeks, and then they just derail. That can be hard because the nerves are, just being damaged, and the predictability of your body really kind of disappears. And it depends if you're in this, you're a pretty stable point, or if your MS is just declining a bit as well as to what's going on. So having a good assessment can really help with that. In Australia, the MS Society has it's actually got a whole new landmark at the moment in Sydney, and that's a place where you can go and you can have a coffee and you can meet lots of different therapists, and you can actually go to the support groups there. get some advice. So that's something you can do as well. Reach out to specialist organisations, MS, Society MS Plus. The medications can be a good thing to do as well. Yeah. Sometimes there are medications that can make things a little bit worse, or they have side effects. You're taking them for one thing, but the side effects actually make your incontinence worse. So that can be a good thing to have a look at as well. Quite an advocate for people that I think may benefit from a conversation about having a catheter placed. It's often the very last thing that we want to do because it puts you at a high risk of infection. And people that have catheters for long periods of time end up where they're much higher risk of complications like bladder stones, and also bladder cancers can develop as well. So if you can manage without a catheter, that's definitely better for your overall health. But when we're looking at the whole person and how much of a struggle life is for you, I think having a conversation about having an indwelling catheter placed, one that stays in for 4 to 6 weeks if it behaves itself, and just change the leg bag, or you can learn to control your urine output with a catheter tap. Sometimes that's an option that's available for you as well. But if your life is absolutely miserable with your incontinence and you've got a condition like multiple sclerosis, which is degenerative, that can be a really helpful conversation to have, so you don't feel like you're absolutely against the wall and you've got absolutely no options at all. Having a conversation about catheter use might be the right time to be doing that for you as well now. So intermittent self-catheters, an indwelling catheter, maybe even a suprapubic catheter could be an option that's suitable for your partner as well. So having a chat to the urologist or the urogynecologist about that, or your MS specialist, might be worth doing. Yeah.
So our next question is, what sort of percentage of people that self-intermittent catheter end up having a more permanent type of catheter? I self-catheter 9 to 10 times each day, but occasionally worry that if something goes wrong, I might have to have a foley or other catheter inserted, which I would find more difficult to fit into my active working lifestyle.
Okay, so in terms of people having self-intermittent catheters and having to catheterize themselves, that's what happens if you can't empty your bladder properly. So if your bladder is too full and it's lost its ability to contract itself all the way back down again, and that urine has nowhere to go except back into those ureters that go up to your kidneys. So we need to protect your kidneys from having too much fluid around them. So we might teach someone how to catheterize themselves. That can be a really helpful thing, and that's sort of a step in between being able to wee and having to have a permanent catheter in all the time to constantly drain that bladder out. If you're managing to catheterize yourself 9 or 10 times a day, that's really great. So we want to make sure that you're able to do that as long as you can, if that's something you need to do. So the first thing is make sure that we're actually protecting your urethra. So that means that when you're inserting this tube, it's as slippery as we can make it, and you're inserting it with gentleness and no force. So you want to have a catheter that has a lubrication on it, one that doesn't go tacky when it dries. So often catheters have the PVC solution in it, which PVC is actually what you were getting in glue when you're a kid. Yeah. So if you get your catheter and you take the lubricant that's on it, if you're using lubricated catheters that come already lubricated, or they've got a sachet that you burst and lubricate them, let that dry and see how tacky it is when it's dry. And then throw that one away, don't use it. But that will help you to know how slippery it is, because often those catheters go in lovely and slippery, but by the time your bladder's drained out, it's had a little bit of time to actually dry a bit. When you're pulling that catheter out, it picks up little cells that are on the lining of your urethra, and you can get really small microtrauma. So if you're catheterizing yourself 9 or 10 times a day and you're doing that for years, we really need to look after your urethra, that tube that you wee out of, to make sure it stays nice and healthy. So we want a really good quality catheter, the right size catheter for you as well. And we want to make sure that it's got the right kind of lubrication on it, so it's super slippery. One reason that can make you go from catheterizing yourself to having an indwelling catheter is if you've caused some trauma to yourself with your catheters. So you may have a stricture in your urethra now, or some narrowing from scar tissue. that sort of thing, that might constitute having a permanent catheter placed, just to rest that urethra or make it easier for insertions. If you're having more and more trouble as time goes on with getting that catheter in, it's definitely time to have a conversation with a continence specialist nurse or a urologist, as you talk to them about how you're doing the procedure, how it's feeling, how it's going for you. Do a bladder scan. Let's see how much residual you've got, all that sort of thing, and let's just work out the best way forward for you.
Our next question is, what is the connection between type 1 diabetes and bladder leakage? If there is one, is only hyperglycemia related, or can a good A1C still cause issues?
Okay, so now we're really getting into conversation about diabetes on this one. So the connection between type 1 diabetes and bladder leakage, I think when we're talking about type 1, we can talk about people that are living with type 2 as well. So is there a connection between type 1 and bladder leakage? If there is one, is only hyperglycemia related, which means high blood sugars, or can a good A1C still cause issues? So the A1C, or the HbA1c, is the blood test that you get that measures what your blood sugars have been like over a 3 or 4 month period. And that tells you how high your sugars have been, how well your body's been producing the insulin to help bring those sugars down, or how much insulin you've needed to help balance that sugar intake that you've had. So having high blood sugar, this is how I explain it to my patients. Let's say you're bouncing a basketball down a tunnel. It's quite a rigid plastic ball, and the tunnel is, let's say it's made of silk. So it'll bounce for a while, but after a little while, it'll start to cause little tears in the side of the tunnel, because that basketball, or those sugar molecules that are in your blood, they're quite large. If you looked at your blood under a microscope, you'd see the sugar quite clearly. They're large molecules, so they cause a lot of damage when there's a lot of it for a long period of time. And the tunnels that get damaged the most are the really small, fine capillaries. So the small capillaries in your eyes, or your fingers, or your kidneys. So when there's damage to those areas, especially anything to do with your urinary tract system, your bladder, those little blood vessels that are, they're also nerves, they really interrupts the messages and the way that they perform. So if you've had high glycemic events, or you've had high blood sugars for even a short period of time, you can cause that damage. If you have high sugars for a long period of time, you'll start to see quite a few things not behaving the way they used to. Maybe your eyesight's not as good as it used to, your kidney function's starting to go down, you've got this weird tingling in your fingers, all that stuff happens because your sugars have been too high. So we need to try and bring the sugars down. We need to try and bring that HbA1c reading down. So for a long period of time, your body's at a better baseline, and the damage isn't being done. What can happen is that you've already had that episode. So you've already had that damage happen. So even if you've got a good HbA1c, the good A1C, and your blood sugars are at a reasonable volume, you can still see this bladder leakage and this damage that's being caused. So what we're really talking about here with this question is, yes, it's possible to see long-term damage and irreversible issues that we're trying to stagnate and stop and not get worse, but the damage can already be done by these large amounts of sugar that have been in your body for a while. So yeah, you can have a good A1C, but you can still have bladder issues, if that explains it. These conversations are often really long ones I have with people.
So our next question is, hi, I am completely incontinent since a prostatectomy in 2016. I am taking duloxetine, which, although helps, the side effects, mainly constipation, is not good. I have tried Betmiga, but it doesn't help. I would welcome suggestions for other possible remedies.
Yeah. Well, my friend, I think I would say at this point it's time for a really good assessment and a good chat to find out what's going on for you. Yeah, these medications are helpful. I believe that duloxetine, it's an off-label use for the stress urinary incontinence. Duloxetine can be used for a lot of reasons. Yeah. Betmiga is a medication that helps with an overactive bladder, helps to calm it down. And it's one of those medications that's less likely to cause cognitive side effects. So that's a good one. It's a good one to be trying. But if it's not helping and you're not seeing any change in your symptoms, even though you started taking a medication like Betmiga, it's time for a proper full assessment with someone.
So we're coming down to our last few questions now. So our next one is, after prostate and bladder cancer, both removed, I've had a neo-bladder for 8.5 years. Should I regularly self-catheterise to minimize the risk of mucus blockages or leave it alone? I've never done it, but now have an annual flexible cystoscopy check of the neo-bladder condition.
Yeah, this is a really complex question. It's a bit beyond basic bowel and bladder education. If you've had a neo-bladder formed, you've gone through a long, hard journey. So my thoughts are with you, and well done getting this far. In terms of catheterizing yourself to help with the mucus, I would say that that's a conversation you need to have in person with a continence specialist. Sometimes mucus forming surfaces in our body actually tend to create more mucus when we stimulate them. So that's a longer conversation to have with somebody, and it depends on what other symptoms you're having, if you're having any urinary symptoms with this neo-bladder. But I think your specialist would really want to talk to you about this without you sort of making that decision alongside a practitioner who's less senior. I think talking to the surgeon that actually formed the neo-bladder for you is a good idea if you've got a good relationship with them. That you're having an annual cystoscopy to check, I think is really great, and that sounds like you're engaging with that health practitioner. So that's good. Keep going, keep asking the questions, and keep educating yourself, reading up on it, learning how your body works with it, so that you can actually give that support to other people that've got the same questions as you.
Awesome. So our next question is, I've had incontinence for quite a few years. Physio hasn't worked. I have to wear pads 24/7, larger at night, and it is affecting my life. I can't swim, I can't exercise. Is there an operation that can fix it?
Yeah, so that's a bit of a broad statement. Incontinence for a few years. Physio hasn't worked, and wearing larger pads at night, so you've got greater incontinence at night, and you can't swim, which is a real shame, especially if you're in Australia in summer and you enjoy swimming. Is there an operation that can fix it? So for a specialist to recommend an operation, they need to do a really good assessment on what's going on. So get yourself a GP referral to a urogynecologist who can do a pelvic assessment as well. That might be a male client as well. So a urologist would be a good person to talk to there. And keep asking questions and get a good assessment done. Yeah.
So our final question for our video today is, I am very incontinent. I've had a mesh sling twice, once 18 years ago and another time 2 years ago. I'm very tired of wearing nappies. I've had physio. I've been taught pelvic exercises, and I'm now seeing a new specialist, and she has suggested Botox to be put in. What are your thoughts?
Yeah, for sure. So this has been a long journey for you. Yeah, I can appreciate that. So you're definitely not alone. When it comes to Botox is a product that will often inject into our faces to stop us from having frown lines. And it's a little bit like that in the bladder. It stops the muscles from contracting. So Botox it's a treatment where they'll do it with general anesthetic. Every now and again, you'll be offered it with sedation, but it's a better procedure to have if you're under general anesthetic, if you can. And they'll put little injections, about 30 injections, all on the inside of your bladder, and put a small amount of this Botox every time. The good thing about Botox is that it's not permanent. So after sort of 6 to 12 months, it will have worn off. Botox really stops that bladder from contracting as hard and as much, but sometimes it can work a little too well. So you might find that you actually can't wee at all when you wake up, or even a few days later, you might find that your body's just stopped being able to wee at all. And that's why when the doctors recommend doing Botox, they'll also send you off to the continence nurse to learn how to catheterize yourself as well, just in case. In case that happens, you don't want to have to go to emergency department and sit there for 10 hours with a bladder that won't empty when you're climbing the walls trying to wee. If you can pop a catheter in yourself, that gets you out of that danger zone and keeps your kidneys happy. So in conjunction with Botox therapy, we want you to learn how to catheterize yourself if you can as well. Sometimes it's a bit tricky for people. So it's definitely worth something considering. But I would say with that question that you've provided, have a really good chat with your continence nurse, because there might be a few other things that we can recommend to you to try and make life a bit easier. Yeah.
Awesome. Well, thank you so much, Rachel. That is all of our questions answered for our video today. And we really appreciate you being here with us and using all your expertise and knowledge to give some great advice. And thank you all to our viewers for watching. Again, if you want to go back to part 1, that one talks a little bit more about general health, so you can visit our channel and click on the link to that video as well, which will be in the description below. Yes, all right. Thank you so much for watching. We'll see you guys soon.